Hi, everybody. We're back. Now, this particular lecture is going to be about hemodynamic medications. I would watch this after the introduction to hemodynamics lecture. And these are some of the meds that you have learned how to calculate in your pharm class. But now we're actually going to talk about if you used them on a patient, how would that look? So I am going to again share my screen. Okay, that doesn't look right. That didn't go well. Let me try again. Share screen. Still doesn't look right. Okay, hopefully this will work. All right, so when we talked about open heart surgery, or when we talk about open heart surgery, we talk about things to help or control or manipulate the blood pressure and the hemodynamic of the individual. So what we're going to talk about here is what we call chemical management. What kind of medications can we give to try to influence or alter their cardiac output, their blood pressure, the pulmonary artery pressure, the different hemodynamic measurements that we might have in their body anyway. And in this particular lecture, we're going to be going to a lacrosse match. That's what we're going to. We're going to be fighting our way to try to rescue somebody's blood pressure. And we'll take the slideshow from the current slide. All right, here we go. All right, so we're introduced in pharm lab, our pharm lecture, to inotropic and vasoactive agents. Okay, so entropy or inotropy or inotropic medications are drugs, to be more accurate, are drugs that are used to increase the force of myocardial contraction, stronger snap, thus improving a better bolus out, better cardiac output. These generally are best influenced in a central line if you're going to infuse them. The rationale is infusing more centrally, you're going to get the response better. And a lot of these drugs can be very irritating the vessel. So you might not get the response you're looking for, and you may irritate and ruin the IV access if they're given distally. So almost always, these are given in the central line unless you don't really have other options. So when we talk about inotropic medications, some of the inotropic drugs, in other words, creating that snap, positive inotropic, or digoxin. Okay, so we don't give that an IV push. You can, don't give it an IV drip. You could IV push it. You could give it oral. There are other ways, but that one never comes in a drip. Isoprel would actually come in a drip. Calcium, you can push calcium. Ionized calcium sometimes pushed. You can take a pill form, which isn't really for hemodynamics. And it can be infused in an IV drip. Dopamine and dobutamine. If I think about dopamine, I think about more to help the blood pressure. On a low dose, we'll talk about that in a second, it helps renal perfusion, more for blood pressure, systemic, and dobutamine, which is more generally given for cardiac output. But they will both raise your blood pressure, and they will both increase the heart rate, whether you want it to or not. Epinephrine, everybody knows about epinephrine. It's what you can push it in a code situation. But we're managing somebody's blood pressure, we generally put it in the drip form and regulate the rate. Most of these are things you do on microspecula per minute. Norepinephrine is another inotropic to increase that snap. Amrinone, milrinone, and vasopressin are all things to help raise the blood pressure and or help create a better snap. There are not as many things that are negative inotropes that we give, but because usually we're trying to rescue the blood pressure and get it up and get some better cardiac output or pull their vasotone in. But quinidine, Inderal, and barbiturates are things that actually have a negative inotropic effect, sort of flattening things, let's say. These are used to improve contractility, better snap, augment cardiac output. So if we put a little manometer in there, we measure, it means each bolus of blood coming out with each heartbeat is bigger to manage hypotensive state if they just have low blood pressure. If there's poor organ perfusion, their kidneys start to not function well. We may put somebody on a low dose dopamine drip to help perfuse the kidneys better. And we also have to realize if you're beating the heart up more, you're positive inotrope, you're also working the heart more. So we may use these on somebody with a really bad heart. Well, we have to accept the fact that as you go up higher on these doses and put in more things, you're also kind of beating up the heart more, so to speak. So inotropy affects the strength of the cardiac contraction. Now, this is a lot of the stuff, if you remember, you just got tested on this at the beginning of the class, so I know you know how to do it, that things might be regulated mics per kilo per minute. And then you could recalculate that to say, well, what do I put the pump at for cc's per hour? And that's the math you guys can memorize. You practice that long formula. Luckily for us, that most of the time when you go in the ICU, there's a pump and the pump will do it for you. But you really, beginning your shift, you want to do the math because pumps can make mistakes. They can be broken. People can set them incorrectly and you just assume they're correct and they're not. The wrong bag could be hanging or the wrong dosage in the bag. So even though you know the pump will do it for you, part of your AM assessment is what's in that bag, what's the pump set at, and can I say that is what it's supposed to be? Okay. So when we look at a bag, just to review, well, I'm not going to review the math. You guys know that. Okay. That intro there. Okay, let's talk about dopamine. We're going to go through some of these meds individually. Okay. So dopamine or intropin is another word for it. It's an endogenous catecholamine. Okay. So if we infuse that at a low dose level, so it would be like 1 to 3 mics per kilo per minute. Remember, this is a med that works relative to the size of the individual. So we put the amount of mics we're giving based on the size of the patient, and then we regulate it based per minute. You go up, these are small increments, like we might change from 4 to 60 cc's an hour. It's always a small number. And some of these meds I'm about to go over can have a very strong effect with a small change. So a mild dose of the beta-1 activity, okay? That means it dilates the renals and the peripheral vascular. So at a really low dose, you're not necessarily going to get improved blood pressure, okay? But mostly when you put it on for a low dose, it's because somebody's kidneys are starting to fail and you're trying to help diffuse the kidneys better. You get a mild increased contractility, a little better snap, and a slight increase in the heart rate. But when you're going beyond that and you want to get their blood pressure up, you may be running this 4 to 10 mics per kilo per minute. At 4 to 10, and generally what you would do is say, the order might be written, dopamine to keep the blood pressure above, 120 over 70. Okay, let's say that's the order. So you, the nurse, would start the low dose, start the dose low, and slowly, every 10 minutes or so, maybe increase at 1 cc an hour until you get up to the reasonable blood pressure you're trying to get them to. So your increased contractility occurs, more of a snap. It'll also increase your heart rate, which we generally don't want in these patients, but it's a side effect, and it'll enhance their blood pressure. At the same time, you have a reasonable renal perfusion. It doesn't magically prevent renal failure. It just helps perfuse the kidney. It'll increase the GFR, the glomerular filtration rate. And the onset of infusing something was within a couple minutes. You're not waiting an hour for this response. If I go up a little bit on the dose, I wait a couple minutes, I should start to see the effect. Again, this one, it's cause extravasation. In other words, deterioration of the vessel. So again, we don't want to, unless it's the only way we have to run this peripherally. So again, we want it in a central line. And generally it's used for hypotensive shock. Then dopamine, when we get up there on the dosage, 10 to 20 mics per kilo per minute, that's our limit. If it's not attained, in other words, I can't achieve that blood pressure of 120/70, if that's what the orders are written at, you might not going to get it. As you get beyond, at this level, I should say, you're predominantly an alpha receptor is stimulated. And going higher than 20 is not recommended. It's actually against the guidelines, because at this point, you're not going to get more benefit, and you get more problems. So generally, if you're having trouble, they would start on another med, a secondary med that acts slightly differently to try to get the effect you're trying to get. As you go up in the dose, you get more vasoconstriction, more clamping down of the vessels, which will increase the blood pressure. But it also you can get too much tachycardia, where you may have to back down because they just don't tolerate it. It also stimulated increased systemic and pulmonary congestion, which can be problematic depending on the patient. And certainly as the dose goes too high, there's a greater risk for ventricular arrhythmias. And the alpha effect begins to depress, because you're clamping down enough that you're depressing renal perfusion. So the low dose helps renal perfusion. The high dose too high a dose can actually hurt it. The mid-range generally is the sweet spot when you're trying to get the blood pressure up. Again, we usually give this in a central line, because it'll if extravasation occurs, it can cause a lot of damage if it leaks outside the vessel. So you can actually burn the tissue around there. Regitine is a medication. If it does infiltrate, and that was your only site, you had it running peripherally, you need to stop the med right away, get a new site, and you shoot sub-Q Regitine around the area to help minimize the damage to the surrounding tissue. Dobutamine, or Dobutrax, is a synthetic catecholamine. Usually run this 2 to 20 mics. There's increased contractility, so you get that positive snap, positive inotropy, and increased heart rate. It's primarily a beta-1 effect, and you get a mild beta-2 effect, so you get some peripheral vasodilation and bronchodilation. So depending on the situation, that can be good or bad. It also increases your systemic vascular resistance, so it tightens up on the periphery. It's very much like dopamine, but it's more expensive. And generally, dopamine is given more to raise the distal blood pressure. Dobutamine is more often used in a depressed cardiac situation. You're looking for better cardiac output. So used generally for marginal cardiac output, or if dopamine is just too profound tachycardia, or you're actually getting excessive urine output from the dopamine, you might lower that drug and then add this one on. It decreases the peripheral vascular resistance. Yeah. So for instance, if I have a post-op CABG, coronary artery bypass graft patient, I might get dobutamine to increase that contractility. And then remember, the onset is in like 1 to 2 minutes. So I turn it on at 5 cc's an hour, watch, because you can see effect. You might see effect right away. And the other thing about these is the half-life's very short, 1 to 2 minutes. So if I'm weaning somebody off the ventilator, off these strips, generally it's like a cc, wait 5 minutes, a cc, wait 10 minutes. You're going to see the effect somewhat rapidly. And so you watch your flow sheet, and you can see you're weaning somebody, and if they're not tolerating, you see their blood pressure sort of drifting down over the next hours. So generally, these are weaned over several hours, kind of slowly, to make sure the patient tolerates the weaning, because clearly they needed it, right? So you don't just turn these off and walk away. Oh, it looks better, turn it off. No, you wean it slowly and see if their hemodynamic stability maintained. Epinephrine, certainly popular. I like this picture. I threw it in here because this is, a typical ICU patient. So you got the main pump. You can see 2 main pumps here. 1, 2, 3, 4, 5, 7 drips. Not surprising. Then And we got a pressure bag here for the hemodynamics. There's 2 pressure bags for the hemodynamics. And so it can be a bit of a zoo in the room. So you'll notice, see how the little sticky labels on there? The nurses will label every pump so you don't have to waste time thinking, okay, which line was this? And following it all the way up. Everything's labeled. But when you come on in the morning, check your labels, make sure everything matches. And then generally, a lot of ICUs, the nurse will close down to the patient. Where the central line's at, there'll be little labels on both ends of the IV, so people can quickly get access to what they need to get and not make mistakes. So epinephrine it's a little different rate. You're in the decimal range here, 0.02 mics per kilo per minute. It's an endogenous catecholamine. We produce this anyway, right? It increases the cardiac output by increasing heart rate and stroke volume. It's a beta-1 inotropic agent, and it can cause tachycardia arrhythmias, just like dopamine and dobutamine. The alpha, hang on, let me shoot this story. Sorry about that. The alpha action is powerful. It's a powerful vasoconstrictor. It can result in increased systemic vascular resistance and an elevated blood pressure. So it's obviously an incredibly strong drug. Again, little bitty, we're changing it 1 cc, then going up another cc when we're regulating their blood pressure. Commonly used for borderline cardiac output. It also relaxes the bronchial smooth muscles, and so it has a strong beta-2 property. So what do we do? It's one of those things we give when somebody's having an allergic reaction, right? And they're having bronchospasms. Okay, so there's another reason to give it. In the cardiac ICU, generally we're giving it, and in a trauma unit, it's for shock to pull their pressure back up. It increases myocardial oxygen demand, so it does beat it up as well. So it's your first line drug in ACLS, and you've all probably heard. Some of you have done ACLS already, for VFib, for pulseless arrest, for bradycardia, and shock. So it used to be a lot more fun to run codes. There were so many drugs we gave. Now it's like, well, epi, oh, maybe we'll give epi again. Oh, it's been 5 minutes. Okay, let's give epi. So they sort of narrowed it down. Story. Okay, so I have a friend of the family who is a little histrionic, one of my daughter's friends in her 20s, and she's highly allergic to certain items like peanuts. So her and her mother were in New York, and she bought a quickie chewy bar of some sort and missed the fact that it had peanuts in it. And so she panicked. She could feel her airway closing, and she's a panicky type of personality anyway, so I didn't help. And her mother, like, just get in the car, because you knew there was a hospital close by. So they drove as fast as they could to the hospital, ran inside, and she's running to the door saying, I'm going to code. I'm allergic to nuts. I need epinephrine. I'm going to code. Well, if she's yelling at you, she probably doesn't need epinephrine if she's talking to you. Either way, they brought her in, and somebody gave her epinephrine, which probably if she's sitting there talking to you, she doesn't need it. And what happened was, yes, her bronchioles relaxed, but it was too much. And she ended up having a myocardial infarction. She had a small MI. And this is horrible. This is a girl on the tennis team, right? High school tennis team. Of course, now she's in college, but she's obviously an athlete. And had partial loss of vision because the arteries in your eyes are very small. And they gave her a whole, ampule and just clamped down on her eyes. So after that, they decided she's sensitive to epinephrine, so she carried the pediatric vial with her. But knowing that patient, she didn't need the epi in the first place. I personally know her. I'm like, she went in there all histrionic and screaming. She don't need epi. Anyway, so it just gives you a vision of how strong it can be. But it's a miracle worker if you're running it in a drip in a patient in the ICU. Another drug, isoprel, isoproterenol. Again, we're in the decimal range. So we're up here with epi, we're in the decimal range, 0.2 approximately. Here it's about 0.05 to 1 microns per kilo per minute. This is not as commonly used. You'll hear about it in the Brady scenario for resuscitation because it does give you a marked increase in heart rate. So if I have severe bradycardia and for some reason we don't want to put the external pacers on or we just want to buy some time, and we gave a dose of atropine that helped, but only for a little while, you can commonly we put them on an isoprel drip, and then you've bought yourself some time to look into a pacemaker. It will rise the cardiac output as well, and it has a beta-1 effect. So it relaxes the arterial smooth muscles and decreases the pulmonary vascular resistance as well. And that can be important for some patients, especially like right heart failure or very fibrotic lungs. It has a great increase on the myocardial oxygen demand. Bam, bam, bam. It is working that heart much more. So they have a greater risk of ventricular arrhythmias when they're on the isoprel drip. It's used for right ventricular dysfunction because again, you get more snap, but you get that pulmonary vascular drop down, and because it has a favorable effect on the pulmonary vascular bed. So it can be useful. Amiodarone or milrinone is sort of an updated, newer version of, pharmaceuticals that invented this. The loading dose, this one you load. So the other ones you just start the drip and then slowly squeak up on the cc's per hour. You're about 5 to 15 mics per kilo per minute to range. The loading dose is about 0.75 milligrams per kilo. So you give them a bolus, okay, and then you follow it with the drip. It has an increase in cardiac output without beating up the myocardial so much. But you get that positive inotropic action. It has a vasodilation effect to enhance left ventricular output. So if you lower the preload, less coming back, and the afterload, open the periphery, right? Then the left ventricle is not working so hard to beat against that pressure. It's a non-catecholamine, so there's a little change in the heart rate, which can be a benefit depending on the patient. Unlike the other catecholamines we just talked about. This one's a little tricky though. It has to be diluted in sodium chloride. If it's in dextrose, it will lose its potency. So it'll all be hanging in normal saline. Now, you might see, depending on the policy of the hospital, but when people have central lines in and they'll run the drips, they won't put, okay, let's say you have IV tubing and you've got 5 drips. You don't put one IV next to the patient and then stopcock back about 12 inches, but the next drip in, stopcock 12 inches back, the next drip in, because the guy back 5 back would take 1 cc an hour or 10 cc's an hour to take, 5 or 6 hours before you get the effect. So you'll always see little stopcocks in each drip as close to the patient as possible, close together on a little stopcock. This one, depending on the policy, it may have to be in a line by itself or it has to be close. So they're infusing very close, so within 10 cc's it gets into the patient. Does that make sense? And which is another reason why you don't change these drips fast, because if I have 5 drips together in the same line and I go 20 cc's, some of that one, everything else is getting rushed in as well. So you always creep up and down. So sodium chloride's an issue, which limits its potency over time. And this one's a little funky though. You have to watch the platelet count. And if you have a patient on this, they've been on it for a few days, we're very careful with that platelet count. And the negative part is if you take them off because the platelets start dropping, it's slow. It may slowly come back over a week or so to enhance platelets. So there's a little danger in that. And the half-life's not as fast. The half-life's 3 to 6 hours. With some of those other things, the half-life was minutes. You still wean slowly and you monitor them for hours. And this one's dangerous. And again, drips would be by themselves. So your push line always is separate from your drip lines. You would never run an antibiotic in with your drips. You would never push a quick med in with your drips because then you're bolusing inotropes that are going to change your blood pressure. So the drips are always together and isolate it. You would have to have a separate line that you'd push another med in, or give a unit of blood, or have just a maintenance IV go on, or antibiotics. The drips are isolated in their own little world. But it's dangerous to give this with Lasix. Trying to think if there's anything else I wanted to bring up. There's another one which I don't have a slide on, and I'm not sure how popular it wouldn't be on steroids anyway. Levosimethonin. It's a new positive inotrope medication. It's something else that's out there. We're going to go over these today. Now, norepinephrine levofed it's a weird one. Hello. He went to the doctor today and got his teeth cleaned. He's miserable. Sorry. Oh, poor little thing. Anyway, I don't know if you can hear him in the background. He's like whining. Levofed. Levofed is a potent peripheral vasoconstrictor. Strong stuff. So it's interesting because it was unpopular when I started working in the ICU, and because it was dangerous, because it's such a severe vasoconstrictor. And then they had the dope, the butamine, new things were coming out, which were more popular because they were newer. And Levofed was on the dark side. And it's interesting, in the last 10 years, you'll see, oh, they're on Levofed drip. I'm like, really? Because we used to call Levofed leave them dead. And now you'll hear on the news sometimes, you'll see a patient who'll come in and they survived their shock state and they were on Levofed, but they lost an extremity because it's such severe vasoconstriction and clamping down. So it's a strong drug. But the patient lived, and that's the trade-off, right? So Levofed's a potent peripheral vasoconstrictor and an inotropic stimulator. It works by making the blood vessels very narrow, which increases the blood pressure. So it clamps down. It stimulates alpha receptors to stimulate vasoconstriction. This is not a mics per kilo per minute drip. If you'll notice here, it's mics per minute. So Levofed's one of the oddballs, because a lot of them are mostly mics per kilo per minute when you do your math. This one also can be very difficult on the tissue if you would run it peripherally on its own and extravasation occurred. In other words, your vein went bad. Again, subcutaneous injections of registine would be necessary. It has a rapid onset, like some of these other drips, and half-life is very short. 1 to 2 minutes, it's gone. So it's a continuous drip infusion. Okay. Vasopressin. Not so much given as a drip in the ICU for hemodynamic reasons, not so common. It's an antidiuretic hormone that you produce anyway, right? Pituitary hormone that acts to promote the retention of water by the kidneys and increase blood pressure. It causes smooth muscle contractions of the capillaries, arterioles, and the venules. This one also is units per minute. Okay, so it's an IV drip, and you can see in the decimal points here, 0.01, 0.03. More commonly used if I have a diabetes insipidus scenario. We'll mention this again under head trauma. And so if there's damage, you can have what we call diabetes insipidus, and you're walking in, that guy's urinating out, 300 cc's an hour, 400 cc's an hour, like, holy moly. So we put them on vasopressin because it's an antidiuretic hormone, right, for the pituitary, because the pituitary is damaged, and that can correct or help correct the issue. Certainly, bleeding abnormalities is another issue because it clamps down, a reason for usage, and sometimes a systole and a cardiac arrest. Now, ACLS is constantly, the Red Cross, whoever's coming up the rules, constantly changes things. So the last rotation a couple of years ago, when they were upgrading what you do in a code, your option was to give epi every 5 minutes, And then one time you could offer a bolus of 40 units IV push in lieu of epi in your rotation of giving men during a code situation. That is now out of ACLS, and I think the reason was epi and vasopressin, statistically, neither of them necessarily anybody survived, and it wasn't like one was better than the other. So they're always trying to keep it as simple as possible so they don't make mistakes and have to get frustrated. So vasopressin, you may see somebody in a code ask to infuse it, even though you didn't learn it in ACLS because they took that out. It doesn't mean you can't give it if you're the doctor writing the order, right? One of the things we do with the diabetes insipidus is they're on the drip for vasopressin, and then you, the nurse, would have the IV going in replacement. So if the urine's 300 an hour, the next hour I give them 300. Urine's 200 next hour, IV's at 200. So you change it every hour based on output. So usually if there's some sort of destruction of the hypothalamus or the pituitary. Okay, so those were all things that give you inotrope snappers, so to speak. A little bit about vasodilators. These are used to decrease systemic vascular resistance. The other guy was a lot of shock people with poor cardiac output. You need to give them some snap, right? And help tone them up so they get some sort of circulation. But they're meds that do the opposite. They decrease preload, they open it up, so what's coming back to the heart might not be as much, and decrease systemic vascular resistance, so the heart that's attempting that weakening left ventricle is attempting to pump out, it doesn't have to work as hard in order to pump out. A popular one, been around forever and a day, as we're continuing with on the cross match, is nitrous phosphide, or SNP, or you hear somebody call it nitrite. Those are all perfectly good. This one is a microkilo per minute IV drip. Never boluses, it's a drip, and it's really strong. 0.5 to 10 is the range it might be running. It relaxes the arterial smooth muscles, so it decreases systemic vascular resistance and pulmonary vascular resistance, thus lowering the blood pressure. It has actually an arterial and a venous dilator. Now, this is a fun drug. So you may have somebody with, let's say, have a FemPop bypass. They're getting a rotor-reader job with a femoral artery, and they're a hypertensive individual just anyway, or they're getting carotid endarterectomy. For some reason they had surgery, and they don't want them to bleed, right? Because they just sewed on their carotids, for goodness sake. So they keep, the order might say, keep the blood pressure systolic under 120. So your job is to have that drip going, and if he creeps up, you got to go up. If he creeps down, you go down. And it's literally a cc here, a cc there. It's little bits to get the reaction you need. Very strong. So one time I can't remember what the lady's issue was, but she was on a nitrite drip. And I went in, and the pump was going off. I had air in the line, no problem with the pump. It was driving me crazy. And I'm taking care of her, so she has an arterial anemia, so I can see her blood pressure every second. And I'm messing with the line, trying to get the bubble out, and she got a little bit of bolus of nitrite. I'm like, whoa! Her blood pressure was whack. I'm like, oh, turn it off. Waited a few minutes. That's it. It came back up. I'm like, oh, for goodness sake. So very sensitive. You know, every cc matters. So why are we giving this? It's a smoother, right? So it can vasodilate, so the heart doesn't have to work so hard. Number 2, reduces left ventricular afterload. So what the left ventricle time to pump against, it opens it up so it doesn't have to work so hard. Used when peripheral vasoconstriction is present. If they're so clamped down in the periphery. Now, you may see a patient who is on blood pressure medicines to get more snap. They're on dobutamine, they're on epinephrine. So that they're on things that are going to cause vasoconstriction and to make things clamp down and get a bigger snap. They may also be on nitrite at the same time. Okay, you're thinking, wait a minute, can we just turn one of those off? No, because this is to take the afterload work away, and the other one's to help increase the cardiac output. So even though it sounds like they're contradictory, they're all helping cardiac output and SVR. So sometimes you need to lower the systemic vascular resistance, poor vascular resistance a little bit, at the same time having something else that's creating more snap. That's why you'll see when you go in the ICU, you're like, wow, this guy's on 6 strips. And so you start looking them up, and some of them aren't doing the same stuff. One of the issues with nitrite that all the textbooks talk about, and you'll see the residents every once in a while ordering a thiocyanate toxicity level. I've never seen it, and I've had tons of patients on nitrite for days and days and days and days. But it is a potential side effect that you get toxic from the nitrite. Again, I've never seen it, and I've seen people on this for days, I mean, literally weeks at a time. But it is a potential toxicity. This also is protected from light. It's one of the little bags, usually a smaller bag, and you'll see some like sort of foil paper around it. So if you see that, you're walking around, there's a foil bag. That's not to ward off aliens as we put our tinfoil hat on. It's to actually protect it from light. The effects of the drug are gone in a matter of minutes. It's a very short half-life. So like the little lady that got the little bolus, I just turned it off and waited like literally a minute and her blood pressure popped back up. But then again, if I change the rate 1 or 2 cc's, I may see an effect immediately. So the reason thiocyanate toxicity would only generally be on somebody that's been on high doses for a prolonged period of time. It is a blood test you can do. And the symptoms would be vomiting, dyspnea, and mental changes, and acidosis. The biggest risk is hypotension, that you'll bottom out too much. Another popular medication is nitroglycerin. Now, there's no oral version of nitrite, but there's nitroglycerin is like the ubiquitous. It's like cotton candy, candy, sugar. You can make a drink out of the sugar. You can make puffy cotton candy out of sugar. You can make liquid out of sugar. Nitroglycerin kind of falls into that category. Look, my son's taking a shot there. See, lacrosse fighting to see the ball. Anyway, you give it different ways. So you might get an ointment. You can have a paper or a patch. The tube, and they put 2 inches on it, and you slap it on the paper on the chest, or the patch with a preset dose, and you slap it on the chest. Now, if you're giving it that way, and it's ordered every 4 hours, make sure you get the old one off. Make sure you find the old patch, because you don't want to be double dipping and have more ointment on there than you need, and clean the site off. And then you don't put the patch, the new dose, on the same location. It needs to be like the other side of the chest, you move it around. Also, if a little trick here, and this wouldn't be on state doors, this is a secret, don't tell other people. But if somebody, we tend to put the patch up high on their chest. But if they start to complain about headaches, because it's vasodilator, right? They can get headaches. Move the patch lower down on their hip, on the torso, and they're a little less likely to get the headache. It's an IV drip as well, which is why we're talking about it, because here we are in an X-Men surge. This one's mics per minute. This is not a mic per kilo per minute. And I doubt state boards would ask you that. I'm almost certain they won't. And you can titrate up to 20. So 20 for nitrite, nitroglycerin, dopamine, dopamine. It's kind of the magic number. And a lot of these, once you get past that, it doesn't, more is not better. It's a venous dilator, reduces preload, so it's coming back to the right side of the heart, and we love it as a coronary vessel dilator, because there's little vessels on the coronary. So hence the pill form, and you stick it right on their tongue, it dissolves quickly, and if somebody's having chest pain. You don't give, you do give, I shouldn't say that. Lots of times, it depends on the patient, okay? So if I have somebody post-op open heart surgery, they might be on a nitroglycerin drip just to keep the coronaries nicely perfused and to lower the blood pressure. And they might also be on nitrite. They could also be on dopamine and dopamine. It's the opposite, to help get more snap. Okay, so you can see where they'll put the cocktails together. This one is a standalone for MI. So if somebody's having a myocardial infarction, but their blood pressure is acceptable, then you might have them on nitroglycerin drip to try to keep the coronaries open, so to minimize the MI. So it helps prevent ischemia by reducing preload. And decreases pulmonary vascular resistance at larger doses. It's used to treat pulmonary hypertension as well. Now, there's a little trick here. There's a great safety question that everybody can giggle about. If somebody comes to the ER or somebody wants to start something in your unit on somebody in nitroglycerin because it is a first-line drug to use when somebody's having an MI. But you got to see if they've been taking Viagra. It can potentiate it, so they'll get too big of a drop in their blood pressure. I can't remember the name of the movie. There's a funny movie. It was the old guy dating a young girl, and he's in the emergency room. He starts having a heart attack, and he's just a 30-year-old girlfriend. He's like 65, and the doc says, "Well, you don't use Viagra." "Oh, no, I don't need Viagra." He goes, "Oh, that's good because if you do, I can't give you this med." The guy, pulls his IV out. It's kind of funny. Scene. Oh, Jack Nicholson, I think, is the guy in it. Anyway, I can't remember the name of the movie. It's funny. What's important about nitroglycerin is that it reduces preload, reduces what's coming back to the heart, and it's a coronary vessel dilator, which some of the other ones don't have that lovely benefit. So you really got to watch the blood pressure. So I may have somebody who's having a heart attack, and I want to give them nitroglycerin to help relieve their chest pain, but if the blood pressure is too low, you might not be able to start it. Now, throwing this in here because you already have your MI lecture on separate video. But this is, I don't know who comes up with these rules. Years ago, it was CHF, congestive heart failure, CHF. And then somebody decided, well, there's no congestion. You can't say that. I'm like, who are the people in charge that come with these magic wands to tell us all we have to say, change what we're doing? And you'll see everybody's still saying CHF, but technically it's not anymore. It's heart failure, okay? HTN is hypertension. HTN, that one sticks. That one's still good. But what's of interest here is, and I like this, I heard a really great lecture on it. I'm trying to give you a quick synopsis here, that heart failure isn't a heart failure, isn't heart failure, okay? So what they're trying, different categories here, and I don't know if I already had a lecture on this, so I just want to throw it out here, make sure you, if you see it in the notes and stuff, you'll understand it. HREF, okay, is heart failure generally because somebody had a heart attack and myocarditis or a weak ventricle. They're lacking the muscle preserve to pump, okay? So a lot of these would be post-MI patients. So think about an 8-cylinder car running on a 4-cylinder engine. It just can't do it. You can't drive. Well, you could drive. They're pumping along, but they're going to have trouble getting up that hill. Right, natural gas car. I know I'm an environmentalist. Maybe I'm going to buy that. I wasn't trained to be a great environmentalist, but I am. The natural gas car going up the hill, just, you can see it just struggling, okay? They're okay at rest, generally, these patients, but they're not going to tolerate exertion. The heart failure REF patient, okay? Now, the heart failure PEF or reserved EF, these are patients with severe hypertension. So their heart's pumping and overworked, so it's pumping against the stiffness. This is where the diabetes type 2 patients came in. Because I think this category came in because we're over here, these three. Diabetes type 2 is just huge. They're most huge people as well. So it's a big part of the population. Also, we have a lot more people living much longer, and they're not just living healthy, they're living with their comorbidities. So we have so many different meds they're on, and we have so many treatments. Who are living longer, but they're not necessarily living because they're spry and still running marathons, right? And then, of course, our obesity population is just, overgrown tremendously starting in the 70s. So it's this giant group of people with the diabetes, the aging, and the obesity. We had hypertension for some time. And then, of course, these three people tend to be the hypertensive ones. So this is the person with a myocardial post-MI that it just can't pump. These are the guys that have stiff ventricles. It's sugar circulating around chronically develops plaque for them. And certainly aging, our aorta and your heart muscle, everything's stiffer, it's less pliable. And then obesity, you have the heart of a person that's supposed to weigh 120 pounds in a 250-pound individual. So it gets overworked. It's different pathophysiology, but both have high event rates, meaning MIs. DAC, DTAG, issues. So the P crowd, the heart failure P crowd, a P ejection fraction basically is, like I said, stiffness. They can't expand well, and it can't feel like it wants to. The blood backs up, and the heart ends up having a low cardiac output. Not that it could have snapped if it didn't have so much overload, right? So the R is for reduced ejection fraction, because it just can't snap. But we have a big growing, and that was usually whatever most people were. But we have a much bigger population used to of the P group of heart failure patients. And then hypertension, the reason I'm throwing that in here too, which is important, and I don't know how much you got on the lectures before us, because it's kind of, this little slide's newish. They reclassified hypertension. So when I was in school, it was 140 over 90. It had to be higher than that to be hypertension. They're like, no. Normal should be 120 over 80. And I'm like, I'm 70 myself. I think they should go all out, lower it. I heard a really great lecture. They were talking about lipids, and they're like, you cannot have too low of an LDL. I'm like, oh, okay. I know cardiologists, he said, that have normal lipids, and they're taking a statin because they think anything lower has got to be good. I'm like, okay, so maybe you could have too low of blood pressure. But the new normal is 120 over 80. So it's, by definition, hypertension if you're 130 or greater, or 80 or greater than 80. So with this tightening, I don't know, maybe they're just trying to create more business for themselves. This tightening guidelines, literally over about 46% of adults have hypertension, which is a little shocking for me because I'm only 32. I used to be 21 last year, now I'm 32. But I'm talking to people I know that are kind of, my compatriots. Oh, I'm on this medicine. I'm like, you're taking drugs? I'm on my blood pressure medicine. I'm like, what? And my lipids, I'm like, what? Who are you that need meds? I'm like, oh my God, I'm getting old. Anyway, 80% of adults with diabetes also have hypertension. Okay, so those two will go hand in hand. And there's a ton of people running around with type 2 diabetes that have not been diagnosed. One of my friends that were in the PhD program with me when I was at UCLA, she happened to be Korean. And for a dissertation, they had a mobile lab, and they drove around. It was like a cultural dissertation. She was looking at hypertension, and evidently there was resistance in her cultural group in the elderly to come in and go to doctors. And so what they tried to do is go to them. So they tried to go to churches and neighborhood type things and bring people in. And what was shocking in her study is the number of people with type 2 diabetes that was not diagnosed. Because they were ruling that out. It's actually I can't remember off the top of my head, but it was like literally 80% of the people she was looking at, but none of them thought they had issues. So pre-diabetes is a glucose greater than 100. It's the borderline diabetes. Those people need to go out and walk. I'll tell you a quick story here. So I had a student in my class a couple years ago, just a beautiful young lady, beautiful, pretty little girl, absolutely gorgeous, pregnant as the day is long. And not an ounce of fat on her, just fit as a fiddle looking. So she's talking to me one day, after my lecture. This was in the wellness class, and she's like, "Well, I'm a diabetic now." And you see her chewing on her carrots and eating all healthy in class. I'm like, "Really?" And I'm like, "Do you exercise?" She's like, "Oh, no, I don't like to exercise." I'm like, "Well, I'm going to cure your diabetes." I said, you got pregnancy diabetes. I said, you need to go walk. She goes, do I have? I'm just looking at me, do I have to? I'm like, yeah. I said, I want you to get the little pedometer out and get your little cell phone out. And I want a couple miles in the morning and a couple miles afternoon. I want you to get the 10,000 steps in. She comes back the next week. She goes, oh my God, my glucose is so much better. I'm like, yes, thank you. Anyway, so big crowd out there pre-diabetic. And big crowd out there, actually. So let's go over case study. Okay, look, they won they're hugging each other, they won the lacrosse match. And this is my son after a game. These guys are twins. They came to the game. They're rah him on. In the ICU, you're caring for a 67-year-old male patient with left heart failure. Status quo, myocardial infarction. 1 day ago. Okay. They put a Swan-Ganz catheter in, so he's got a central line that can monitor his hemodynamics. He's on the EKG and he has a Foley. And I'm sure he had a peripheral ID as well. What your nursing assessment is a low cardiac index of 2.1. Remember, the normal is at least 2.5. And elevated pulmonary artery pressures, 41/20. That's nasty with a wedge of 21. You want a PA, when they did the wedge, it was greater than 30/12, which is good. The normal should be like 5 to 12 range. So again, the PA pressure should be low. That way your right ventricle doesn't have to pump hard, right? To those stiff lungs. Systemic vascular resistance was 1800, which is high. So now I had an MI, right? And if my resistance is high, that left ventricle is going to pump, get stiff vessels. That's problematic. CVPs on the normal high side, 10, so you're not dehydrated. Frequent occasional PVCs, which of course I don't like, but you just had MI. Urine output's less than 30 cc's an hour. So he's got a low cardiac output, but at the same time, if he's not peeing well, it tells me he has low cardiac output. So he's not confusing his kidneys as well as he should. His extremities are cool, so he's clamped down, which I can tell by the systemic vascular resistance of 1800. And capillary refill is delayed. His heart rate is 76, and his blood pressure is 146/85. So in the old days, I wouldn't have got excited about 146/85, but it's technically hypertension. And any high pressure on a heart that just had a heart attack is difficult for that to pump against, right? Okay, so our diagnosis, well, alteration of low cardiac output, he had an MI, and heart failure. He needs afterload reduction so that left ventricle doesn't have to pump against those stiff, tight vessels, that SVR that's up. When it improves cardiac output, give him a little better snap, and certainly want to lower that pulmonary vascular resistance, right? Because again, the right ventricle doesn't have to pump against that. We know that the PAs decrease. Hyperventilation? No, I don't know why. It would normally, but we're not. Oh, bulimia. Thank you. I'm like, hyperventilation, hypervolemia. So if he has an elevated volume, okay, because he is the CVP of 10, certainly that will raise the PA pressure as well. We want to increase pulmonary blood flow by lowering the PVR, and increase pulmonary. He has increased pulmonary vascular resistance. He has not great pulmonary blood flow because the numbers are high, right? Mitral valve and left ventricular failure, mitral valve disease or left ventricular failure. These are things we're worried about. The goal is to reduce the workload on the heart because he just had a MI. Afterload reduction, so the left ventricle had to push against things so difficult to push against. When I decrease the pulmonary vascular resistance, lower that PA pressure, decrease systemic vascular resistance, SVR, so the left ventricle is not pumping against tight vessels in the periphery, and improves urine output indirectly. That should happen, and certainly monitor his arrhythmia. Okay. So what happened? Okay, so they start him on lidocaine drip, antiarrhythmia, or amiodarone, either one would have worked here. In this case, they use lidocaine. Generally, you bolus 75 milligrams of lidocaine, and then you follow up the drip, 2 milligrams per minute, for the drip they put him on. You could also have given an amiodarone bolus, and then followed with an amiodarone drip. Now, some of the options would be dobutamine, because it lowers the systemic vascular resistance. It will increase the heart rate, and it would lower that pulmonary capillary wedge pressure. And then, of course, give you more snap, increase cardiac output. So you'd have to watch his heart rate, but it would improve all the areas that he has problems with. Amiodarone would also help because it lower the SVR, doesn't have too bad of an effect on the heart rate, and it'll lower that pulmonary capillary wedge pressure. So that's good. And will increase the cardiac output and not over demand on the heart by demanding oxygen. So that could be good. What they did was they started dopamine excuse me, dopamine at 7 mics per kilo per minute. And so you work your way up and titrate it until you get a decent cardiac index. So you'd infuse it, wait a while, check another cardiac index, increase the rate a little bit, check another one. Keep an eye on the heart rate so it doesn't, if it doesn't tolerate, it can't go up, right? This blood pressure. Also, you're worried about the increased oxygen demands in the heart muscle. So it's also started on low dose nitrite to decrease afterload, right? To lower the systemic vascular resistance, 0.6 mics per kilo per minute on IV drip, to reduce the left ventricular afterload, what the left ventricle time to pump against, and which is decreasing the SVR, systemic vascular resistance. It will decrease the pulmonary vascular resistance, good, because that number was too high, and ultimately lowers blood pressure, which was 146/80, I think. So we lowered that. And of course, not forget family. Provide patient and family emotional support and encourage the patient to rest because he's pulling up from the fresh heart. I hope that gives you an idea of how you can use these meds to help a patient. Now, I just have this picture at the end. This is obviously a dead person, but it's a coronary vessel. And can you see the little metal in there? That's a stent they put in. And this is, an autopsy. You can see the plaque and the stent that embedded into there. This is a graft on an aorta, Bacon graft on an aorta. And this is a valve sewn into place, a mechanical valve. You see the stainless steel and the sutures around it. I just thought that was fun to show you guys. That's it for this lecture. I hope that makes some sense. And I'm going to stop sharing and stop recording. All right, thanks guys. Have a good one.